Hello, and welcome again to the Surgical Clinics podcast. Surgical Clinics is a bi-monthly publication consisting of review articles devoted to a central topic important to general surgeons. Surgical Clinics has published for over 100 years, and the series and the podcast can be found at www.surgical.theclinics.com. I'm John Vassallo, the managing editor of the series here at Elsevier, and for our seventh podcast, we'll focus on the June 2023 issue on burn management. In this issue of 17 articles, the authors document advances and challenges across the entire spectrum of burn care, from pre-hospital, austere, and mass casualty environments to the intensive care unit and operating room, all the way to post-burn recovery and reintegration. Here to discuss 4 articles from the issue will be our consulting editor of Surgical Clinics, Dr. Ron Martin, senior surgeon from the Department of General Surgery at Pullman Regional Hospital and Clinic Network in Pullman, Washington. Joining him will be the guest editor of the burn management issue, Dr. Lee Cancio, director of the U.S. Army Institute of Surgical Research Burn Center at Fort Sam Houston in San Antonio, Texas. Welcome to both of you, and over to you, Dr. Martin.
Thanks, John. As always, appreciate the introduction and for putting all the work into getting this together. And welcome, Dr. Cancio. It's a pleasure to have you on board with us to discuss this topic, which is both near and dear to everybody's hearts and frightening to many. But I'm sure we're going to have a good time getting people on board with the thoughts and helping them alleviate some of their fears regarding the topic. So I'd like to start with the acute surgical management of the burn patient by Drs. Saraswat and Dr. Holmes. I think part of it is that there are some people like me who've been doing this for an awful long time. We've seen many iterations of how to evaluate people, and where in the old days we focused sort of on age and percent burn equal mortality, and now things have changed enormously. So I thought maybe we'd start off by it seems to me that one of the most things is correctly and understanding what you can and can't do to assess the magnitude of burn injury at presentation. And I'm wondering if you can help us go through how you decide to assess depth of injury, percent of injury, and how you approach it over the first few days to determine what's the nature of the problem you're up against.
Absolutely. The name of the game here really is wound healing and wound closure. So although there's many things that can go wrong with a burn patient during the course of a difficult hospital stay, it all boils down to taking care of the burn wound. So fundamentally, there's 2 aspects to burn care. One is it really is a multidisciplinary team concept. And the second part is, having said that, fundamentally, this is a surgical problem. It's a wound problem, and success or failure depends more than anything on taking care of that wound. So the surgeon really is the centerpiece of this effort, as well as everybody else who touches that patient and deals with that wound. So in terms of that initial assessment, the first thing I ask myself is, does this patient have a big problem or a little problem? And a big problem to me is something that's life-threatening. And that boils down to, first of all, is it a large burn wound? Large depends, first of all, on, is it 20% of the body or greater? In virtually all patient populations, a burn size of 20% or greater is potentially life-threatening. Now, there are patients with smaller burns who can also get into trouble, particularly at the extremes of age or in those with complex medical problems. In those patients, a burn size of 10% can definitely be life-threatening. So someplace in the 10 to 20% burn size range is when we start to get concerned about a potentially life-threatening problem. We consider admission to the burn intensive care unit and so forth. So how do I make that burn size determination? The easiest way to do that is initially using one of the well-known rules like the rule of nines, which is taught in advanced trauma life support, but it has to be done carefully. It's interesting that it's very easy to overestimate burn size by a factor of up to 100%. and that can lead to serious problems. For example, in the military setting, it can cause you to aeromedically evacuate a patient, exposing the patient and the crew to risk when possibly that evacuation could have been delayed or avoided altogether. And certainly here in South Texas, which is a huge catchment area for our civilian population, as well, these decisions concerning burn size should be made carefully. So the rule of nines is a quick way to get an initial assessment. The second way to assess burn size is using the so-called rule of hands, in which the entirety of a patient's hand constitutes 1% of that person's total body surface area, with some differences in the morbidly obese, as you might imagine. And then finally, when the patient arrives at the burn center, we break it down in a little greater detail using a chart which is age specific, called the Lund-Browder chart. The bottom line, though, is that initially we're trying to determine, is this a big enough burn to where the patient needs potential burn center transfer, potential IV fluid resuscitation, and that cut point, like I said, is someplace between 10 and 20%. The other thing I'd like to say is that when you're looking at risk, in particular risk of death, the age plus the burn size remains an excellent rule of thumb. And nowadays in the United States and North America, age plus burn size equals 100, means that the patient has, on average, a 50-50 chance of making it. And that holds true for the patient with the 20-year-old with an 80% burn, or the 80-year-old with a 20% burn, and everything else in between. The final thing, of course, is that we also have to take into account inhalation injury, which adds to immediate risk, loss of airway risk, as well as ultimate in-hospital mortality because of problems like ventilator-associated pneumonia and other complications.
So for the moment, let's exclude the group that's burned as part of a polytraumatic event. So we'll take out the inhalation injuries, we'll take out the ruptured spleens, the broken bones. The part that I think is changing a bit, and I'm curious as to your thoughts. It seems to me that most people can figure out a superficial burn and most people can figure out a burn into fat. I mean, to me, a shallow second versus a deep second aren't necessarily the same animal. And I'm not sure that you can necessarily tell that at moment one.
Yeah, burn depth is important for a variety of reasons. Probably the main one is that it can affect functional outcomes. In other words, if you have a deep hand burn, then that hand is at risk. And you could have long-term, same thing, face, for example, same thing, burns crossing joints. That's where depth really comes into play. So how do you determine depth? You correctly identify that it's pretty easy to determine a superficial partial thickness burn. In other words, a superficial second-degree burn. There's erythema. There's maybe some blistering. If you remove the blisters, you see a glistening surface, but it's well perfused and this sort of thing. What about the full thickness third-degree burn? It may be charred, it may be pale and leathery, it should be insensate or largely insensate. There's no capillary refill in the wound. That's clearly a full thickness burn, easy to identify. It's in between that there can be difficulty. However, and the most difficult this thing to distinguish is between deep partial thickness and full thickness. These are burns that they look pretty opaque. They're pretty insensate. I may not see much in the way of capillary refill, but ultimately the only way I can figure out the true depth of that burn wound in a practical world is to do excision and grafting, take the patient to the OR, tangentially remove that burn down to where I see viable tissue. And that's either going to be in the deep dermis or it's going to be in the fat. So really that decision is made in the operating room. And I don't have to make that decision at the bedside pre-op. All I have to decide is, does that patient need an operation? And which means it's either deep partial thickness or it's full thickness. We're going to operate. Not a lot of effort needs to be put into making that particular distinction. Really, to me as a surgeon, the real question is, does this patient need an operation? Yes or no? And oftentimes, if the answer is no, the patient can go home unless they're medically unfit or it's a really big second-degree burn.
That's excellent advice, and I really appreciate it. My experience on a lot of subspecialty matters, though, is that people's confidence level in saying no, they don't need an operation, or yes, they do, largely depends upon whether they're the person who can actually do the operation. You know, I'm a pancreaticobiliary guy by nature. I dabble in all this other stuff. There's a whole bunch of things that I might be more comfortable saying than others, but it leads me into the next point, because I think in your original comments, I mean, there's the world of surgery, which includes everything, education and theater and our imagination of the mind, and then there's the operative management that goes on in the OR, and this is heavy on the operative aspect of the surgical discipline, you know, a way of life, a state of mind, an approach to the world. And so to me, the thing is once you're in this mode where you have the capability to do tangential excision, complete excision, and grafting, then if you're going to achieve success, it's largely dependent on knowing when, where, and with whom to go. So the pre-op considerations, if we then get back to excluding all those other injuries and include, but if we look at the comorbid state and your resources, tell us how you factor in your preoperative stuff, because I would say that, or you correct me if I'm wrong, I don't think excising a burn wound is stat immediate in most cases. You got a little bit of time to do your homework and put your crew together. So what are the things you're looking for before you're willing to go to the OR? Once you decide you're going to go, make sure that when you go, you're set up for success.
In my view, there are patient-related factors, and then there's technical factors that you need to take care of before you go to the operating room. So the patient-related factors are really key here. Some patients benefit from early excision, and some patients, I think, benefit from a more nuanced approach and a thorough preoperative evaluation, particularly the older patient with multiple medical problems, which represents a good number of our civilian patients here in South Texas, is going to incur substantial risk with one of these operations. So that has to be balanced against the benefits of early excision and grafting. The point I'd like to make about the technical aspects of burn surgery is that if you're not used to doing this operation in your operating room, or if your team is inexperienced, then it's really helpful to develop a pre-op checklist to include the sorts of equipment, supplies, room preparation, and so on and so forth. In our burn center, we are fortunate to have anesthesiologists, OR techs, and circulating nurses who work full-time in the burn center. Other places that I've worked to include while deployed, of course, I haven't had that luxury, and so we have rehearsed and prepared for these operations ahead of time, and we've also limited the extent of what we try to accomplish at any one excision to around 10% of the total body surface area. And I would certainly recommend that to anyone who is less experienced. It's true that in our burn center, we may excise 40% of the total body surface area, but it really is at a single operation. But that is that's a risky proposition, and not for a beginner team, if you will.
No, and I think that applies to a lot of things. I mean, the good news is hyper-specialization has brought us capabilities that we never had on an individual basis. The downside of it is it degraded a lot of capability that we used to have in a lot of places. And I don't want to pass a moral judgment on it, but you see it in every stripe of surgery that you can. In the net aggregate, it's for the better. But it makes it, and we'll get back to how it makes the system highly dependent on a very few pressure points. But so just before we move on to sort of the military aspect of this, any thoughts in particular on grafts or graft substitutes? I mean, I know there's a lot of new stuff coming down the pike and being worked through.
Yeah, there are a couple of new items out there that have proven very useful. There's spray on skin cells now. That product is called RECELL. There is a product that's coming out which will permit removal of burn eschar by means of an enzymatic substance that's called Nexobrid. So these technologies are going to be pretty useful, but I would caution the listener that they are no substitute for, if you will, experience and competence in the basics. Nothing has replaced the basics. No skin substitute is better than the patient's own autograft. No temporary skin substitute is better than cadaver allograft. And no technology is better than an experienced team to include both the surgeon, we mentioned the OR team, and also the bedside nurse. The single approach which I have found most useful for closing truly massive wounds is so-called sandwich technique, in which I take a 4-to-1 meshed autograft and place that on the wound, and I cover that with a piece of allograft. And that permits healing to take place over a prolonged period of time. So that's an example of a technique which has been around for perhaps 40 years or so, and it has stood the test of time. We can only hope that newer technologies in the future may allow us to heal these wounds faster.
Speaking of things that have been around for time and problems, let's talk a little bit about burns in the military world, something you and I have held near and dear at different times in our lives. So we've sort of talked about what you can do in the burn center that has the bells and whistles and the support. Now we put ourselves in austere and hostile environments. So describe for us your thoughts about moving into this forward position with the stressors and how that should affect our thinking.
So we need to be prepared as military surgeons, and I am a retired military surgeon responsible for training the next generation of military surgeons. We need to be prepared to take care of burns on the battlefield, and they have constituted 5 to 10% of combat casualties, and we anticipate that there will be even more burns on the future battlefield in the case of large-scale combat operations, whether that's someplace in Asia or in Eastern Europe or in the Pacific region at sea. All of those scenarios, will likely include a lot of burns, and those burns are going to be cared for by some of our listeners who may not have a lot of experience with that. Here, the key is to focus on the basics, the initial resuscitation, the initial wound care, the performance of eschorotomies, and to get some, sense of comfort with those types of procedures. Then we diverge into whether we're going to be able to evacuate this patient off the battlefield quickly to a higher level of care, or whether we're going to have to keep this patient in our location for a prolonged period of time. During the last conflicts in Iraq and Afghanistan, the typical scenario was that of rapid evacuation of U.S. casualties off the battlefield into the aeromedical evacuation system, and from there on to Landstuhl, Germany. And because of that system, we were receiving large patients with large burns within 3 days of initial wounding at the burn center in San Antonio, Texas, which is truly amazing. In case of large-scale combat operations in the future against a peer or near-peer adversary, we likely will not have air superiority, and therefore those patients will probably not be evacuated in as timely a fashion. So this is going to make the care provided by the team on the battlefield that much more difficult. That team is going to need to be more proficient with fluid resuscitation past the initial hours. We're going to get into the critical care phase after resuscitation, and we're going to have to be adept at daily, aggressive, thorough wound care using effective topical antimicrobials. And then finally, as we get into days 5 post-burn and beyond, we're going to have to deal with the risk of infection, whether that's wound or lungs, bacteremia, and so forth, and the problems of dealing with the septic patient. So a lot of what we currently assume here at the Burn Center as our roles under those circumstances going to be pushed forward. The other scenario that we did deal with in Iraq and Afghanistan, much more so Iraq, was care of local nationals, where we performed definitive care to include excision and grafting and some rehabilitation of local nationals with burns of up to 50% of the total body surface area. And that was challenging. You know, the fact is, without knowing exactly what the future battlefield is going to look like, we do know that there will be civilians, and those civilians who are injured, some of those will have burns, and we will be called on to care for those people.
Yeah, I was going to talk a little bit about that. I mean, and having been in the first Gulf War and the second Gulf War in Afghanistan during high kinetic times, we saw a lot of civilian injuries, and a lot of them were burns, especially not even necessarily with the combat, but cooking fuels and things like this. Now, in the chapter by Doctors King, yourself, and Zheng, they cover this and this, but I think a lot of our colleagues aren't familiar with EMRO or the medical rules of engagement, and those both realpolitik and other politic considerations that come down from command. But the net result of it is that there are U.S. and coalition forces largely in one group, kind of throw the contractors in with them. There's host country nationals, and then there's third country nationals. And host country nationals and third country nationals don't usually get on the airplane to launch tool. I mean, there's a few exceptions we won't dive into here. but so you really do have to take into account geopolitics in your local environment. And our average surgical colleague in the U.S. hasn't had to deal with that as much. And I'm not trying to put anybody down. It's an opportunity situation.
Yeah, absolutely. You know, this was a big deal for me in Baghdad, and I spent a year in the combat support hospital in Baghdad, and we received a variety of civilians with life-threatening burns, and I admitted them and I took care of them over there. You know, the medical rules of engagement were that we could admit patients with life, limb, or eyesight threatening problems and take care of them until such time as we had corrected that particular problem. For example, you got shot, we fixed that, then we transferred you to the Baghdad hospital. I argued that these burn patients, those with extensive burns, had life or limb-threatening problems until I could get the burn wound largely healed. As such, I kept patients in the CASH in Baghdad, the Combat Support Hospital in Baghdad, for longer than any other type of civilian patient. The tactical situation on the ground was such that we had to make space to accommodate possible future casualties in case of a battle, then the imperative was to transfer patients sooner. And so we had to negotiate some of the ethical issues involved with having a high level of capability in our hospital and knowing that that capability did not exist in the place to which we were sending these casualties, these civilian casualties, down the road at Medical City, Baghdad. And I don't think that, like you say, this was not a problem. It's not in the doctor book, right? And it certainly was not in my prior experience here in the state of Texas. But it's worthwhile thinking about, because that's an example of the sort of problem which we surgeons need to be able to confront and handle ethically when we're deployed.
Well, you know, the funny thing you say, it's not in the doctor book. It's not necessarily in the officer book.
Right. It's not.
And there was a line out of the chapter that struck me, in that all disasters are local. And I agree with that in part, but I've sort of made a half a living the last 4 or 5 years out of talking about all disasters have one thing in common, is that you try to co-locate your resources, with the exception of a pandemic, in which case you try to disperse all your resources. So there is one set of disasters that's truly not local, and that's the global pandemic. And the same things then translate problem-wise, because when all of the hospitals lost staffing and all of the hospitals lost capability and all of the transfer patterns get disrupted, and none of them have come back online yet, largely because of nursing shortages and other issues, things that, you know, in the admin side of my past, you know, drive you crazy. We have created the same issues that we now have, in that you have somebody who needs to go somewhere for dialysis, and no hospital dialysis will take him for 7 days. You have somebody that needs a complex endoscopic biliary procedure, and it ain't there. You have a kid. This is here in the good old US of A. So part of what you and I had at our disposal during Operation Enduring Freedom, Operation Iraqi Freedom, and its other iterations, we had an unlimited budget, more or less, for patient movement. And American civilian society doesn't have that. Nor do they have a medical regulating officer who can tell somebody, guess what? You are taking that patient and transfer. You know, it doesn't matter if it's Friday night and you don't feel like it. I mean, you know, you get the call, the 9 line drops, and away you go. You're off and running. So I you know, part of me misses the days when you could rely on the federal government to help you get these things solved. And everybody tells me, if you rely on the federal government, you've got some issues, but I don't believe so. I think it worked very well in the military sector for taking care of soldiers and service members. But we do have these ethical things that come up. And one of the lines from your was the concept of degrading gracefully, which I wish I had thought of, but I didn't. But I'm going to use it again, I promise you. As Oscar Wilde said, don't worry, I will use it somewhere. But you know, you can't always have all the things that you want every place that you want them. And so going back to our discussion, we as a surgical community would do well to convince our regional, local, and smaller hospitals to find ways to increase their self-sustaining capacity for some things that administrators historically have not wanted to spend the money on. And I realize the economics of it, but it is doable, because at the end of the day, I mean, I'm not going to take up this whole podcast with economic theories, but at the end of the day, we have roughly the same cost. It's how we distribute it, how we support it. You know, so political will, economic will, and just doing the right thing. But if we surgeons don't stand up for it historically, nobody will stand up for it for us. So my plea to any surgical colleagues that are listening is hear this and get involved. Just like with every issue with the Clinics Free Right, take this information and use it to influence your community. Pretty pleased with sugar on top. So hopefully they'll take it up. But I do think those people who have had the opportunity to deploy to forward areas, whether it's in a military setting or the NGOs and people who've gone in austere environments, have an awful lot to teach those who haven't had that opportunity about how much you can really get done with not so much.
Yeah, absolutely. That certainly was one of the lessons from Baghdad, was that, as well as from a prior experience briefly on board the Comfort Hospital ship at the beginning of the war in Iraq, is that the key is to understand the basics of care and to perform them well, so that going back to some of our earlier conversation about what's new in the skin substitutes or the care of burn wounds, what's the latest technology? The latest technology may be helpful in expert hands, but what really saves lives is attention to basic skills, such as debriding a wound thoroughly, applying a topical antimicrobial, and repeating that daily. Being attentive to the signs and symptoms of infection, and intervening early in the treatment of those problems. These are the basics. Sure, we've got better stuff now than I did when I started. We've got continuous renal replacement therapy now. That's made a big difference. But has it? Has it really made a difference? And the fact is that post-burn age and burn size adjusted mortality has not changed much over the last 25 years. That is to say, during the entire time that I've been working at the Army Burn Center, the entire time since Dr. Basil Pruitt retired, since when he retired from the Burn Center, mortality has budged very little. Other things have improved, and we'll get to that in a moment. But attention to the basics is the key to success in this particular area. And thus, that becomes even more important in a mass casualty, austere, or military scenario where instead of taking care of 1 or 2 patients at a time in a bespoke manner, I've got to take care of 25 or 50. There, it really matters that we follow clinical practice guidelines, that we adhere to protocols, and that we eliminate sort of variability and sort of guesswork, so that I can instruct a team, okay, you guys, this is what we're going to do for all of these patients today. And that really is the only way to get out of a true mass casualty burn disaster successfully. So there's degrading. When you say we're going to degrade gracefully, that's true, but we're not going to skip on the essentials. It's going to be even more important to do the basics of wound care and patient management well.
No, I think you're right. Success in mass cal events, which fortunately don't happen that often in the US, they more than they should, but is largely about knowing how much you have to do to keep this person alive right now and move on to the next and keep it all organized. And having a team that's well rehearsed and up for it and emotionally up for it, because there's all the second victim stuff and things that go into it. I mean, you burn out your crew, then everybody's in trouble. And, no pun intended on that. But I mean, that's one thing the military is very, very good at, is simulating burning and getting everybody on the same sheet of music. A little harder to get people to take that as seriously back home. But still, I don't mean to pick on anybody. It's just, it's a hard thing to train for something that doesn't happen very often. And it's an easier thing to get people to train for something to know that every day it's going to be like Tuesday. That's going to be what happens day after today, whatever it's going to be. So let's move a little bit. I mean, I could stay on this topic forever, but the basics, it doesn't matter which issue of the clinics we put out. Almost invariably, the lesson somebody needs to learn from it is that you have to know the basics. Anatomy and physiology will strike again. You need to know what the goals of intervention are, and don't get too hung up on the tricks that you use to achieve these. If you don't secure a good diagnosis, you're unlikely to come up with a good plan. If you do have a good diagnosis and you're only good with one tool, it may not work in the situation you had hoped. And we really writ large, I mean, people when they say okay, boomer, but you got to get back to the fundamentals. And I'm not a boomer neither, to make it worse. But still, it's just that is a lesson that everybody needs to hear, and we need to go back to our medical schools and our residency programs, because burn care is largely out of the general surgery ABS rubric now, right?
First of all, what I've learned is that it's hard to learn how to do this type of surgery well. It really takes a long time. Burn fellowship is typically 1 year in duration, but it's really hard to teach someone how to assess a wound, how to do these operations even, how to detect, what doesn't look right. That really takes accumulated experience. And at the same time, like you say, many surgeons don't have much burn experience. And particularly if they're going to be responding during a disaster, God forbid, a mass casualty fire disaster, or what about a nuclear weapon detonation? I mean, a lot of people will not know how to respond, how to take care of that type of casualty. Same thing on the battlefield. We deploy military surgeons, and one of the problems that they need to be able to take care of is a combat casualty with burns. At the present time, the main, in addition to whatever exposure they may have had during residency, medical school, the other way of getting some training in burns is advanced burn life support, which is similar to ATLS. But even that's only designed for the first few hours in an emergency department setting. It's not designed for what we've been talking about here, namely care past the first 24 hours, care into the third to fifth day post-burn, much less anything to do with excision and grafting. So I think there's a training gap here. There's potential for better instruction, better educational programs in this area.
So the last two chapters, I think I'm going to kind of combine them conceptually, but one is on the pharmacologic management, which was written by Dr. Pruskowski, Feth, Hong, and Wiggins. And then the other one was on critical care rehab, written by Jill Cancio and William Dewey. We've talked a lot, and it's been a fascinating discussion for me anyway, about how we get into this, but I try to tell the people that I operate on for non-burn things and the crew that discharge planning begins before admission. Now, you don't know that with a burn patient necessarily, or somebody who gets shot or drives into a bridge abutment, but discharge planning begins at the patient's contact with the institution. And I think you have to be thinking about, where do I want to get this person to? And what are going to be the objectives along the way? And as you mentioned earlier, paraphrased, good judgment comes from experience. Experience comes from bad judgment. Hopefully you can get the experience from somebody else's bad judgment, at various forms, but occasionally it's our own. But still, it takes a while to accumulate the master nuanced expert level of understanding that can't even always be taught. It can be guided and mentored and coached, but somebody has to learn it. It's always the teaching hospital, learning hospital paradigm. They're really learning hospitals. And only former teachers like me go around trying to convince people that what we did was important, because it wasn't. It's just guiding people. But if we look at it in the pharmacology chapter, the three big concepts were: how do we manage pain, hot topic everywhere? How do we manage agitation and address it and evaluate it? How do we manage delirium? And then if we couple that in with the critical care rehab part that looks at the care as described in the chapter as the acute and intermediate and long-term phase, with focus on the acute and intermediate, sort of up to the point where you're dealing with a wound and up to the point where the wounds are closed, then they all sort of, to me, dovetail together.
This area of the psychological or neuropsychological and functional care of a patient with a massive injury like a major burn This is not sort of ancillary or additional. It is really essential. So much so that we are required and we provide rehabilitation evaluation within the first 24 hours of every patient's admission to the burn center. The therapists are involved in the resuscitation of the burn patient within the first 24 hours. They are responsible for taking care of the patient's upper extremities if they are burned in order to prevent or decrease the risk of complications associated with extremity compartment syndrome, for example. They are responsible for maintaining range of motion during a period of time when edema is occurring and the patient's not moving normally. Once we get into the operative phase of care and we're doing excision and grafting, they're responsible for splinting the patient in order to protect our grafts and also in order to guard against contracture formation during the healing process. Then as the patient comes out of dressings, they're responsible for getting the patient moving, combating what is often a very aggressive scar formation process, and then working on activities of daily living so that that patient can get back to school, work, or in the military duty. So this is a lot of work. There's another component to rehabilitation care, which I coined the term critical care rehabilitation, which has to do with the intersection between therapy and the ICU care of the patient from a survival standpoint. For example, just because the patient is mechanically ventilated, is sedated, and possibly undergoing continuous renal replacement therapy does not mean that that patient is not going to get out of bed. Or if they don't, or if they're not able to stand, often they're not able to, we're going to get that patient on a tilt table and we're going to get that patient in an upright position, even though they're sedated and intubated. We need to do so aggressively. We need to do it early, and we need to keep it going during an intensive care stay, which may amount to a day per percent burn or even longer. So if you come in with an 80% burn, you're going to be in the ICU for 80 days or even longer. If I leave you in bed, then you will be immobile, weak, you'll have diaphragmatic dysfunction, and so on and so on. So I believe, and we have some evidence to support this idea, that early rehabilitation in the ICU is associated with survival. And there are physiologic reasons for believing that would be the case. And we have more work to do from a research standpoint in order to substantiate those observations. So that's critical care rehabilitation. The bottom line there is we have to be aggressive both with mobility as well as with maintaining and restoring function. So we have to include both occupational and physical therapy on that rehab team. But the other piece here is the pain, anxiety, and delirium piece, if you will, the neuropsychological aspect. These patients being in the ICU with massive injuries are going to require at some point, at some time or another, plenty of narcotics. They're going to require sedation. They are going to require sometimes massive amounts of narcotics. At the same time, they're going to go through periods of time when they're going to be hemodynamically fragile and susceptible to the hemodynamic adverse effects of drugs like propofol. So our approach to management of these patients with larger burns in the ICU focuses on either continuous infusion of fentanyl or intermittent use of Dilaudid, sometimes OxyContin from the narcotic standpoint. Then we'll use continuous rate infusions of ketamine, typically in the analgesic dose. And then we'll use gabapentin on the presumption that there's a significant amount of neuropathic pain. And then finally, we may use an atypical antipsychotic like Seroquel, for example, for those patients who display a component of agitation. But having said that, there's also a big role for non-pharmacologic treatment of all of these problems, particularly with respect to things like sleep hygiene and reducing auditory stress. And we're starting to explore some topics such as acupuncture as a pain and possibly anxiety management technique. So we have a lot more to do in that area. Longer term, the psychological well-being of these patients is critical. They're at high risk, like other trauma patients, of post-traumatic stress disorder, as well as of affective disorders. Many of them come into the hospital already with psychological illness and or with substance abuse. Many of our patients have substances on board or are intoxicated with alcohol when they get injured in the civilian sector. So as a consequence of this, we now have a full-time clinical health psychologist on our staff who is responsible for the comprehensive psychological care of these patients, both inpatient and then following up on an outpatient basis.
I mean, one of the recurring themes through our discussion here as we kind of wrap up is the importance, absolute imperative, of the interdisciplinary team who is focused and knowledgeable. You need people to really factor in all this stuff. And I think burn injuries to me have always represented that log order magnitude over all the other injuries that we think about. Doesn't matter which old textbook you pick up where they give you a stress response, there's always a break in the curve and you get burns. I mean, they're just in a league of their own. But all this other stuff, if you look at just regular stuff, whether you're taking out somebody's appendix or their gallbladder or their colon or doing a joint replacement, what we learned from doing minimally invasive procedures was how bad we were managing people who had open procedures. Because we were like telling people, I mean, I was there when you kept people in bed for a week for a hernia. It's the stupidest thing you can do. But at the time, we didn't think so. But it was numb. I mean, and now we've gotten everybody better. Now, the crew that I work with now, unless I'm operating at a specific time in the morning, we have everybody on the team together to discuss every patient. And it makes an enormous impact on being able to mobilize them through what's going on, make sure everybody understands. I mean, the surgeons are in charge of surgical patients. Our hospitalist colleagues are in charge of medical patients. It's not a turf war. It's just somebody somewhere has got to take the lead, but it's got to take the lead of a team, not be a tyrant. You got to get everybody on board. And if you do that, your outcomes are just plain better.
No, absolutely. The other day, a colleague asked me whether I currently had a laboratory where I was doing research. And I told him, well, I had left that behind. And currently my main laboratory is running a burn center. And all of the interpersonal aspects of that job. And it is definitely an interesting and challenging job in so many ways, but really it is the team dynamics and having a well-functioning team, like you say, from different specialties, all focused on the burn patient. And I believe, like you say, captained by a surgeon, is the key to success. It is the fundamental sort of technological advance that occurred in the 20th century was the formation of teams in places called burn units or burn centers dedicated to improving burn care. So not just doing it, but also iteratively studying it and improving it. And so that goes back to the first chapter by Dr. David Herndon, where I asked him to talk about the multidisciplinary burn team. And one of the things he highlighted in that chapter was the importance of research to achieving excellence in burn care. And it's fundamentally the desire to do things better and to continuously improve that I think is a key aspect, key component of that successful burn team.
I think, real-time face-to-face communication, or at worst, phone to phone, gets everybody involved and everybody understands where they are, and everybody has a chance to voice their concerns that might otherwise slip under the radar. And this open loop, either texting or I put it in a chart somewhere where you may or may not find it. When you find highly effective teams, especially burn centers, polytrauma centers, neurosurgery groups, any number of people, electrophysiologists, it doesn't matter. You get these people together where they work face to face with each other, or better still, you deploy downrange and you live in the same tent. There's nowhere to go. You're going to talk to each other after work as well as during work. I mean, you're on a fob or wherever you are, it's a pretty small footprint. That's what improves care.
Yes, absolutely. Yeah, that's so true. Supposedly surgery is a high-tech occupation. It's a set of technical skills. That's just the beginning, right?
Yeah.
The real challenge is the interpersonal part.
And including the patient, their family, and their support. So, but I mean, I think as you get closer to the end of your career versus the beginning, you start to realize how almost all problems are just variations of the same problem. And you think they're all different at the beginning, but they're not. They're these system things, and you get people together and you support people, you grow, you learn, you take feedback, you find out what the patients want, you find out what society needs, and you figure out where you fit in. And it's never perfect, but hey, life's like that, We can't thank you enough and all your colleagues for putting this issue together. This is the kind of stuff that people need, and they need a place to reference it in one place where they can get a tremendous amount of bang for their buck and then start reaching out to develop the expertise. But as a platform, you and your colleagues just did a phenomenal job, and we're so indebted to you.
Oh, thank you so much. It was a lot of work, and it was my pleasure.
Thank you, Lee.
Thank you for joining us for the Surgical Clinics podcast devoted to burn management. The 4 articles discussed, as well as 13 others, are in the June 2023 issue, Volume 103, Number 3. The series is available for individual print or online subscriptions. Visit www.surgical.theclinics.com to subscribe. The series is also on the Elsevier digital platforms Clinical Key and Science Direct. Be sure to follow us on Twitter @Surgical Clinics, and you can subscribe to the podcast through Apple, Google Play, Spotify, Stitcher, and Amazon Music. Thanks for listening.